Now, brain formation begins right around that month mark is really critical. This is when the neural tube and pores close at each end, and now the brain starts to develop because you've closed that rostral neural pore. We've already talked about the 3, 5 vesicle stages and their derivatives, so we're good there. These epithelial cells that line the neural tube, they divide to produce the neurons and glial cells. So there's a little layer of cells, epithelial cells, that are right next to where the cavities are there, and those grow out and layer like onion, like layer on top of each other to grow your cerebrum and so forth out from there. Okay, neurons differentiate appropriately after migrating to a final location. Once they get to where they're supposed to go, they kind of turn into the cell or to do the job they're supposed to do. Neurons find their targets by testing the chemical environment, their growth cones. So as if you look on a microscopic kind of, you can see these cells. They run on, the neurons run on these glial highways. The glial cells start to form, and then your neurons kind of creep along the glial cells to get up to where they think they're supposed to be, that they're programmed to be, and they have this little growth cone that kind of like pokes out and tests, is this where, in the chemical environment, is this where I'm supposed to stop and be located? Then once they're located in the spot they're supposed to be, they kind of fully differentiate into the type of neuronal cell that they're supposed to be in that region of the brain they're supposed to be. Just fascinating. Some neurons, though, if they don't make connections, they die off. And that's especially during that first couple years of life. You know, if you've got neurons that find a place, but they don't end up being used, your brain kind of gets rid of them. So, and part of that use is dependent on sensory environment and stimulus, you know, during those first few years of life. If you don't use them, you lose them, kind of thing, you know. And then it's hard to ever get those back. Then once they're, you know, gone, it just makes it more challenging. And then you get, over time, with just your environmental input, you get this neuronal scoping, axons retracting in neuronal breadth and growing and retracting just to kind of shape the overall connectivity of your nervous system. Further development at the cellular level of the nervous system, we said myelination begins in about the 4th fetal month. Okay, during this process, you get myelination beginning, occurs in different rates in different systems depending on the region of the nervous system, but most myelination is done by the age of 3. And so there's a term you'll sometimes hear of as growing into deficit, because sometimes you don't know if a child has a deficit until they reach that certain level of a milestone or whatever, that they're supposed to start showing that behavior, and that's kind of growing into deficit. We'll show you how to do a Babinski test in one of our labs. It's testing kind of the integrity of the motor system in adults. When you scrape the bottom of the person's foot, usually with your thumbnail or a combination of your thumbnail and the end of a reflex hammer, the handle of a reflex hammer, you kind of scrape up the lateral border and across the met heads. You should, in an adult, the big toe should go down. Big toe should go down, and the little toes usually stay together, and maybe they wink a little bit in the down position. However, if you have a damaged central nervous system in an adult and you scrape the bottom, you get big toe going up and the little toes flaring out. Okay? That's also true if you're under the age of 3. Okay? And, well, really, it could be normal up to the age of 3, but most kids once you get past 3 months, they lose that Babinski response. Then they have more of an adult-like Babinski response where the toes are down going. But between 1 and 3 months, so if you got a little niece, nephew, or somebody you can do that with, and they're between that 1 and 3 month stage, you scrape their foot, their big toe is going to go up. And that's because you haven't formed enough myelin on your nerves. So it's almost like there's damage in an adult. If you damage those like nerves in, you know, the pathways in your spinal cord or your brain, that's like damaging the myelin, essentially what you're doing. So it's kind of gives you this appearance, and we don't know why, the mechanism behind that and all that kind of stuff, but that's just a quick and dirty way to, if I've got a patient complaining of symptoms that I'm not sure fit, like an orthopedic problem or something like that, and if maybe they have like a big bulging central herniation of their disc, and they're having some weakness or numbness in their legs, and I scrape the bottom of their foot and their toe goes up, this is surgery, because their disc is bulging enough into their spinal cord to actually impact the descending upper motor neuron pathways in the spinal cord that's not something that can be I'm going to fix with physical therapy. So. Development of disorders of the nervous system in utero and around the time of birth, utero and perinatal damage. We mentioned anencephaly, where you get this. These are neural tube defects, where the anencephaly is when you get failure to close of that rostral neural pore, the superior neural pore. It doesn't close all the way. Okay, so because you have to have it closed to be able to start growing your cerebrum. So if it doesn't close, you're just left with kind of rudimentary brainstem right there. Okay. Most fetuses with this condition die before birth, and almost none survive more than a week after birth with that. So this would be an example of that. So you see this failure of the neural pore to close. So this is just some brainstem remnants here with no cerebral development of that. Other things that are related to kind of neural tube defects, this is an Arnold-Chiari deformity. Inferior cerebellum and medulla are elongated and they protrude into the vertebral canal. It's often associated with hydrocephalus, because we'll show you a picture here. If your brainstem and your cerebellum starts to slip into that foramen magnum, you close off those exit points. Remember where those little foramina, those little openings, the foramina luschka, foramina magendi, that are coming out underneath the cerebellum? Well, the cerebellum gets squished down through the foramen magnum. It closes those off, and then cerebral spinal fluid starts backing up into your lateral ventricles, fourth ventricle, third ventricle, because you've closed those off. So that's why they have to then do, that's when they'd have to do for sure surgery on that to open those up, or put a drain in, into your cerebrum. It can cause tongue, facial weakness, deafness, weakness of lateral eye movements, and coordination of movements, because those are where the cranial nerves that supply those come off right around that area, at that right in the medulla, and that can get squeezed also in that foramen magnum. So you can pack those cranial nerves that are coming off the brainstem that are also going to get squeezed in with that foramen magnum because of this. So this is showing you that potential defect here. These little green dots, this is showing you where the foramen magnum is. This is where the hole is that your brainstem comes through. All of this should not be down here. All of this should be up above that line. And so this is that protrusion, this herniation essentially of the cerebellum down below the foramen magnum, and because of that it puts pressure on the brainstem here, and you have several cranial nerves that exit right in that area, and if you push on those, you're going to have impairment of those cranial nerves, as well as potentially cerebellar, like coordination deficits because of that. But also you'll notice they've also blocked up those openings, and you can actually see this is kind of a little bit of an enlarged fourth ventricle back here. It's normally not quite that big, and the lateral ventricles are probably also enlarged, so they probably backed up that cerebral spinal fluid flow because of that, blocking those holes. This is the ventricular shunt. So this is where they put this nice little tube right through your brain into the ventricles, and so for hydrocephalus, and then the tube runs just underneath your skin on your skull, and you can palpate it. It goes into your neck area, and then it goes down underneath your clavicle, and then they just curl that tube up, and if it's in a child, they put extra length because the child's going to grow, right? So they just pile in another foot or two of tubing down in their peritoneal cavity. Once this goes in your peritoneal cavity, your body reabsorbs it, recycles it. But oftentimes protein deposits develop somewhere along this tube and block it up and clog it up. So eventually you have to change it out, and the more times you change it, it's hard on, your brain doesn't like to have things poked all the way through it and replaced and so forth. So you do see some challenges over the course of a lifetime with somebody with a ventricular shunt, having with infections and just repeated surgeries and having to, pierce into the brain. They try to find out, they know certain regions that they can kind of poke through that are likely not to cause any really large focal damage. They're going to avoid your speech centers and your motor centers. They're going to go somewhere probably more in that parietal association area where there's not distinct regions associated with function, and kind of slide it in one of those regions. So. Also, neural tube defects, a big common one is spina bifida. This is where the inferior neural pore doesn't close, resulting in a neural tube defect. There's different types or severities, okay? Going from least concerning or least impairing to most impairing, you're starting with spina bifida occulta is the first one. Neural tube tissue does not protrude through the defect, and there's typically no impairment. And about 20% of the population has spina bifida occulta. And really what it tends to lead to is you actually see a failure to actually close of the vertebral arch. So they're missing a vertebral arch down in that lower lumbar sacral area. They're missing a vertebral arch down there, but no nervous system tissue is protruding through that or anything like that. One identifying feature of people that have spina bifida occulta, they have often a little patch of hair right there over that area where it fails to connect there, that vertebral arch. The next level is a meningeocele. Meninges are the dura, arachnoid, and pia. In this case, the meninges protrude through the defect. There is a possibility of some impairment with this. It's not a lot, or it might be mild, but you're not really impacting the spinal cord or nerves technically with this, because it's just the meninges that protrude out through this defect, but doesn't mean you couldn't have a little bit of defect. Then you get to meningomyelo. So meninges, and then this M-Y-E-L, myelo, or myelo, that's spinal cord. So this is where the meninges and some neural tissue start to protrude, and there will be some degree, especially of lower extremity dysfunction, because this is down in the, caudal neural pore down in your lumbar spine, so it's not going to affect your upper extremities, it's just going to affect lower extremities when this happens. Then the most severe is called myelo. This is spinal cord or nervous system tissue, myeloschisis. A schism is an opening, or it failures to close at all. So it's filleted open back there, and there's just open tissue, and you've got spinal cord and spinal nerves being exposed to the environment. Okay, that's myeloschisis. So here is some of those different versions here. This is Netter. So this is the spina bifida occulta. So here you see this failure to form of the posterior vertebral arch, and it's like almost an opening, but it's not quite, because there's some fatty tissue in there, maybe a little partially developed vertebral arch. And then in this case, you see the little patch of hair back there in that region that you might see if somebody has a spina bifida occulta. You're going to see patients who come in for you for back pain because of spina bifida occulta, because also sometimes the facet joints in that area, it may be a little misformed, and you may, when you first get them on the table and start doing your physical exam, you notice that little patch of hair, and they have pain right there, and they haven't had imaging done, you probably can assume that they might have some spina bifida occulta, and that could be contributing to some of their back pain. And that's, again, 20% of the population, so that's something that you might see out there. This is actually an X-ray image, and let me change color here. This is a gap in the vertebral arch right here at that L5, S1, right? And it's usually right around that L5, S1 region. So there's, you can see the level above. You can kind of see the vertebral arch in here, but here there's just this. You can see the ends where these should connect here and show some kind of a structure there on that, but it's not there. So that's that spina bifida occulta. So here's the meningeocele. Meningeocele is this one. So here's the opening. There's the failure to close, but all we have is the meninges out here, which is going to be your dura and arachnoid. The pia, remember, the pia mater is on the spinal cord itself. It's that little, just very thin, couple cell layer thick that's microscopic that you don't see. But so the pia and arachnoid are here. Then this is all filled with cerebrospinal fluid. This pouch sitting off the back, Again, that could lead to some impairment, but most likely not, or minimal impairment. Now, this is a meningeomyelocele. And so here we have the meninges that are out here, but now the spinal cord is actually out inside of this meningeomyelocele, and some of the spinal nerves, the cauda equina, is out here all encased in that. And now what happens is that, especially during birth, Usually inside, the baby is okay because it's padded, it's in that amniotic fluid and sac, and there's not, but as it's being born, if you don't know this is going to happen, pressure and trauma to that sac as the baby's coming out of the birth canal can damage the spinal cord and the nerves. This is actually looks like a myeloschisis. So this is where you see there's like actually opening to tissue here where that isn't fully closed. It would be a myeloschisis where you've got that opening to the, this would be spinal tissue here and nerves and so forth that could be exposed. And then you're likely to, even in utero, get some damage with that before even the birth process. The interesting thing now is they're actually able now to go in and do surgery in utero on these kids and try to close that and protect it before they're before they do a C-section and so forth, so they can prevent some of that. So, forebrain malformation, the prosencephalon fails to divide normally with varying degrees of facial abnormalities. The most severe is this thing called holoprosencephaly, with failure of the brain and midline structures to divide. Some guy, what was his name? You can't remember the name. So he found what was the reason he called the Sonic the Hedgehog gene? Was his daughter?
He discovered it, and his daughter was reading the comic books.
Okay.
So the babies had like
These spiky
projections on their face. He called it
the Sonic Hedgehog gene. So interesting. So. Knew there was had to been some backstory to that, so is one possible cause of this. So this would be a severe form, this holoprosencephaly, with failure to divide of the midline structures here. So you're not seeing two eyes, two sides of the nose, those kind of things. And you would also, if you went in, the cerebral hemispheres would likely not be divided into two separate cerebral hemispheres. So, and these babies obviously don't survive. Other things that can damage the nervous system in and around birth would be exposure to too much alcohol or drugs. Can definitely take a toll and wreak some havoc on the nervous system. Fetal alcohol syndrome we mentioned, you may be working in the school systems and so forth and seeing some of this with kids. Those are some of the collective things you'll see. With cocaine or opiate abuse, disturbance of neural proliferation, cocaine and some other drugs cross the placenta pretty easily, and it stays in fetal circulation. So kids come out born and they're going into withdrawal, so, and they have to deal with that, which not good for any adult to go through withdrawal, let alone a baby with a very sensitive developing nervous system to go through that. So you're just likely also to get less, complex and connections in the nervous system and appropriate connections being developed at critical times. Just showing you some of the facial abnormalities that you might see with fetal alcohol syndrome. Once you've seen it a few times, you just pick it up right away. Oh, that's fetal alcohol type syndrome, as you'll see. Intellectual disability. With intellectual disability, you see significant deficits in the morphology, the structure of especially the dendrites and dendritic spines. They just don't have as many, and so they don't get as much connection. And there's abnormalities that prevent good connectivity between neurons that can lead to this, these more profound intellectual disabilities. Cerebral palsy, which you guys will do in peds, it's a catch-all term. Really everything fits under this. Anything that's a non-progressive damage to the developing brain. So it's something that's affecting the central nervous system. Okay, this is not a peripheral nervous system problem. So it's any damage to the brain. Typically spina bifida is a spinal cord problem. Cerebral palsy is a brain cerebrum problem, okay? And for any reason that you have lack of blood supply or oxygen, but you could even be a stroke. You could have a fetus that has a stroke in utero, But any reason that you lack blood supply to a region can cause damage to that particular region of the nervous system. There's different types, the general classifications of, and there's a lot of variability within these types, but there's spastic CP. Spastic CP is where you typically have the majority of your damage is around the ventricles the lateral ventricles and the internal capsule. The internal capsule is the big white matter axons coming from your motor tracts, going from your cerebrum down there. And if you damage, those are the upper motor neurons, those white matter tracts, then you're very spastic in nature. So that's spastic, hypertonic, spastic cerebral palsy. Sometimes they get damage to the basal ganglia structures. And the basal ganglia plays a role in movement. And sometimes you damage certain parts of the basal ganglia, you get too much movement. And it's this kind of dance-like, writhing kind of movement you get called athetoid movement. So they might, some kids have this more, they're not spastic kids, have a lot of spasticity and so forth, but the athetoid, they're kind of doing this kind of, it looks smoother, the movement, it's kind of almost dance-like, and they're kind of moving their trunk and their limbs and just kind of sitting there, and they don't have as much spasticity. That's an athetoid variant of cerebral palsy, which is more indicative of damage to the basal ganglia. But believe me, you can have somebody who's got damage to both the basal ganglia and the white matter tracts around the ventricles, so you can have a spastic athetoid. You can have double things, or they're more athetoid with a little bit of spastic, or they're spastic with a little bit of athetoid, nature to their movements. Ataxic would be more of a true, not spastic, not athetoid, but when they do move, it's kind of very, ataxic. When they move and walk, it's very ataxic. So who was with me? You were with Crystal yesterday, who's got multiple sclerosis. She's a classic ataxic cerebellar lesion type person. But when you test their reflexes, they may not be spastic, but you only see it during fine movements and movements where they've got this lot of ataxic movement. Fast pendular movements look very uncoordinated, but they're not really spastic, or they're not writhing. And athetoids, they tend to be moving even when they're not supposed to be moving. But ataxic, if they're just sitting there not doing anything, they look pretty normal. As soon as you just ask them to move, it's very, or their trunk starts to get, when you ask them to move, and their steps are very, anything that's caused with difficulty with repetitive, quick movement, especially. And as I mentioned, the mixed. There's a lot of the kids, and I should say adults, because these kids become adults. And so there's actually a really big need out there in the neuro world for kids. They get a lot of this care with CP as they're going through the school system until they're 21 or so, and then they fall out of the system. And then they're getting older, and now they're having age-related issues with arthritis and so forth, and mobility issues. And then once they start moving, a lot of times they start putting on weight. And then it becomes even that much, it's this vicious cycle. And so there's a big population of adults with CP who could really benefit from PT and regular wellness fitness programming that's accommodating to their deficits and challenges. And I've seen some just really bad cases where I get called in way late in the game in a home health setting or something, and I'm like, wow, what happened? And they don't even know to get. I thought I was done with physical therapy once I turned 21. I was out of the system, and nobody ever thought to they need to be doing PT their whole life. You can't just stop once they get to 21. Summary of developmental disorders: majority of CNS during development generally occurs before week 20. That's kind of maybe a good one. More minor and localized damage may occur after week 20. This is an interesting stat. 75% of spontaneously aborted fetuses, miscarriages, are due to CNS malformations. So, nervous system changes during that infancy, first few years of life. There's certain critical periods that are really important for those axons that are competing for those synaptic sites and making sure you get the right connections. Without those proper stimulation during those times, you can really set somebody up for a lifetime of challenges. Sweet, got done in time. So let me pause this.